You can do the YouTube.
YouTube live.
You have started the live over.
Yes, ma'am. Done.
Yeah, already started live. Yes.
1 minute is there, no?
Done.
Yeah, already started live. Yes.
Should
Yeah,
we start?
at 8. Let us start.
Okay, good evening, everyone. Good evening, all.
Good evening,
I
everyone.
welcome you,
Good evening.
everyone. So, without any delay, we are going to start our second classroom, Nebaoi Classroom, today. So, first is welcome address and introduction of the expert, Dr. Monish Grover, by our president, Dr. Shubhamoy Chakraborty. So, Dr. Shubhamoy, please.
Thank you, madam. Good evening to all. Today, the second classroom of Nebaoi is going to be started. Regarding Professor Monish Grover. Professor Monish Grover, he did his MS ENT in AIMS, New Delhi. He is also an FACS and PGT HHM, former senior residents, PGI Chandigarh, senior professor and additional superintendent of SMS Medical College, Jaipur at present, ex-secretary Cochlear Implant Group of India, president of All India Rhinology Society. He has done more than 1,300 cochlear implants and mentored many centers in India and abroad to help to start their cochlear implant programs. He has received many awards, notably State Level Merit Award for work in the field of deafness by Honorable Chief Minister Srimati Vasundhara Raje Scindia on Independence Day. More than 100 publications he is having, notably newer classification for cochlear malformations, which has been referred to as SMS classification. He is the chief editor of Textbook of Radiology for Cochlear Implants by Thame Publications. He is also the editor of Advances in Implantation Otology by Springer Publications. His hobbies are photography, tennis, and travel. So with this, today we are having the great expert, Professor Monish Grover, with us. We are very much thankful to him that in spite of his busy schedule, he has consented to be the expert of this classroom. Thank you, madam. Thank you very much.
Thank you so much, sir, for those kind words.
Welcome, Manish. I
Thank
have a
you
privilege
for
to work with you. I have seen you
Yeah.
working. So,
I know it's
I
been
know you.
a wonderful relationship with you for such a long time that during my post-graduation and now it's so good to connect through Zoom also.
Yeah, definitely. So now I request Dr. Anjan Bhuiya, our secretary Nebaoi, to introduce Dr. Anuradha Deka, who is the speaker.
Good evening to all. Actually, today's class is the second of this session, and it is the 21st, 21 classroom at a stage that we have started last year. So, so in today's classroom, we have our speaker, Dr. Anuradha Deka, who is presently is a senior resident of ENT in Negrims. She did her MS in 2023, and she also did DNB in 2025 from Negrims itself. Her current post is senior resident, and she already published 5 publications in the Index national and international journals, and attended more than 5 national and regional conferences and many live workshops, and presented papers in the national conferences. Her area of interest are the mastod surgeries, endoscopic sinus surgery, thyroid surgery, and parotid surgeries. So with that, I welcome Dr. Anuradha Deka for her presentation on middle ear anatomy and physiology. Welcome, Dr. Anuradha.
Thank you
Thank you,
so much,
Dr.
sir. I hope I'm audible to everyone.
Yes, you
Yeah,
are.
very much. Yes.
Yes.
Okay.
Thank you, Dr. Anjan. Now we have our two moderators, Dr. Gautam Nayak and Dr. Tilak Bhattacharjee. So I request our chairman, scientific committee, Dr. Hiranya Bora Baido, to introduce our moderators. Hiranya Baido.
Thank you, Fojia. So today is the second classroom of this year, of this session. So I welcome you all to this second Nebaoi Classroom. Today, I welcome our moderators. First of all, Dr. Tilak Bhattacharya. He is presently working as Senior Medical and Health Officer at Konoklata Civil Hospital, Tezpur. He passed his MS from Guwahati Medical College in 1995, and he is a senior member of Nebaoi. Secondly, I welcome Dr. Gautam Nayak, Professor and Head of the Department, Nalbari Medical College. Dr. Gautam Nayak is well known for all of us for his surgical skill in the field of ear surgery. I welcome both of our moderator to this session. Thank you.
Thank you, Hirinu Madam. So may I request Dr. Anuradha to start her project, and Dr. Rohan, please slide share.
My slides are visible to everyone, I hope.
Yeah.
Okay, thank you. Can I go ahead with the presentation?
Yes.
Yeah.
Please
Thank
start.
you everyone for giving me this opportunity. Today I'll be sharing with you gross anatomy and physiology of the middle ear with mucosal compartments and middle ear electrophysiology in a brief. So as we know, the middle ear consists of 6 walls. It's a compartment. Anteriorly, we have the tensor tympani muscles, eustachian tube opening. Laterally, we have the external auditory meatus with the tympanic membrane. Inferiorly, the jugular bulb is there. Posteriorly, we know it is the mastoid and editus, that is the opening to the mastoid. Then medially, we have the inner ear, and superiorly, we have the middle cranial fossa. So when we see the rough diagram of the middle ear space, it is not the same size all around. So in epitympanic area, it is around 6 millimeter in width. Mesotympanum around 2 millimeter in width, and hypotympanum around 4 millimeter in width. Anterior posterior diameter is around 15 millimeter. The volume of middle ear comes about 2 milliliter. When we go into middle ear cleft, how I want to describe this, we need to know few terms here. Once we see the ear, we can see the tympanic membrane. Just behind that is your mesotympanum. Anterior to it will be the protympanum. Posterior to the mesotympanum is your retrotympanum. Below is hypotympanum, and above is epitympanum. When we come into the lateral wall of the middle ear cavity, what we have is the upper part is nothing but a bony scutum. Then in between we have the tympanic membrane, and below is the bony wall of the hypotympanum. So you can see here properly and also in the diagram. So there are 3 important holes in the lateral wall of the middle ear. What are this? We have the anterior canaliculus through which the chorda tympani enters, and the posterior canaliculus in the posterior part of the tympanic membrane through which it exits and enters into the facial canal. We have the pterygotympanic fissures also, which attaches the anterior malleolar ligament and transmits anterior tympanic branch of maxillary artery. Now coming to the roof. Roof is nothing but which separates the middle ear from the middle cranial fossa. So it is mainly formed by the petrous and the squamous part of the temporal bone. Important structure here which we have to keep in mind is the cog. What is the cog? Cog is something which projects from the tympanic tegmen tympani caudally to the head of malleus. What it does is that it divides the whole of epitympanum into small anterior epitympanum and bigger posterior epitympanum. So whenever this is important in relation to the surgeries, whenever we are doing our surgeries, then we have to remove the cog to go and take out the disease in the anterior epitympanic part also for proper clearance. Inferior wall, which is the floor, it separates the jugular bulb. So in some cases, congenitally, it may be dehiscent. So whenever we should be taking some care when we are digging on that area. Fine. And there is something known as inferior tympanic canaliculus that is present at the junction of the floor and the medial wall of the cavity. It transmits the tympanic branch of glossopharyngeal nerve, which is known as the Jacobson's nerve, and also preganglionic parasympathetic fibers. Posterior part of the floor, we have the stylet eminence and roof of the stylet process. Coming to the anterior wall. Anterior wall again can be divided into three parts. We have the upper one-third, middle one-third, and the lower one-third. Upper one-third is mainly present with pneumatized supratubal recess. Supratubal, the term itself means something above the tube. So definitely in the middle part there will be some tube. That is the eustachian tube orifice that we have in the medial part. Just above the eustachian tube orifice we have a tensor tympani muscle also. And the lower third is a bony plate which separates the middle ear from the carotid artery. It can be very thin at times. It can be around 3 millimeter thick also. So we have to be very careful when again we are exploring that area. The lower one-third is again perforated by caroticotympanic nerves and tympanic branch of internal carotid artery. So this is the diagram. I hope you can see with the laser pointer. This is the supratubal recess which we have shown here. Then this is the tensor tympani muscle. This is the eustachian tube opening. This is your anterior wall. This I have told you about the cork which separates the epitympanum into a smaller anterior epitympanic recess and a bigger posterior epitympanum. I hope that is clear to everyone. Now coming to the medial wall. See, there are multiple structures in the medial wall, but for the PGTs I am saying this. In case they have asked you to draw a diagram of the medial wall, you can give a schematic diagram which I have shown here. My diagram is not very good, but you can draw your good diagrams there. Here I'm showing you the level of geniculate ganglion, and from there this is the tympanic or the horizontal part of facial nerve. Then from the second genu downwards, it is the vertical or the mastoid part of the facial nerve. The main impression in the medial wall is your promontory. That is nothing but the impression of basal turn of cochlea. We have two bony spicules coming out from there. One is above is ponticulus, below is cubiculum. And below this cubiculum, we have the round window niche. And above the ponticulus, we have oval window. These are the things in your middle wall. Sorry. Two important things in the middle wall is your oval window and round window. Why it is important? Because these are the windows which opens to your inner ear. Inner ear you have scala vestibule, scala media, scala tympani. So the oval window opens to your scala vestibule and the round window opens to your scala tympani. Oval window is mainly kidney shaped opening, 3.25 millimeter into 1.75 millimeter. Round window is 2.3 millimeter into 1.9 millimeter, and it is triangular in shape mostly. Oh, sorry. While knowing about the middle ear cavity, you should also be knowing about the facial nerve canal. Here I have already shown you a diagram where you can see the tympanic segment, second genu, and the mastoid segment, right? Coming to the posterior wall. Posterior wall, the main part is the irregular opening that we have, which is the aditus ad antrum. Means it is the opening to the mastoid antrum. Below that we have the fossa incutis, which hosts the short process of incus and the superior ligament. We have a pyramid, which is mainly the conical projection, which houses the stapedius muscle and the tendon. Something very important here is the retrotympanic spaces, which we have to know. So mainly in PG level, they used to ask about the retrotympanic spaces, and when you have to draw a diagram, I have shown here how a schematic diagram you can draw is the facial nerve again, the horizontal segment, then the vertical segment you draw. Main prominent parts is the promontory, then ponticulus, cubiculum, round window, oval window. Behind is your aditus, below that is the fossa incutis, externally or laterally is your tympanic annulus and chorda tympani. Then these are the four superior retrotympanic spaces. Here, on the other hand, this diagram shows almost a anatomical structure. Here, just behind the oval window, this area is your posterior tympanic sinus. Below is the sinus tympani, where the boundaries are the ponticulus, cubiculum. Then you have laterally is the vertical segment of the facial nerve, and medially is your promontory. Fine. Just lateral to it, we have the lateral tympanic sinus. Above that, we have the facial recess. These things are very important to know about the facial recess boundaries and the sinus tympani. Facial recess, already told you, superior is the fossa incutis, medially is the vertical segment of the facial nerve, laterally is the tympanic annulus, and chorda tympani. What is the importance? This facial recess mainly gives an access when we are doing posterior tympanotomy. Okay, mainly done in our cochlear surgeries. Then we have sinus tympani. These boundaries are superiorly ponticulus, below is cubiculum, then laterally is the pyramid, medially is promontory, and posteriorly we have the posterior semicircular canal. This is again an endoscopic view of the same. This is the promontory, ponticulus, cubiculum. This is the sinus tympani. Here is the mastoid segment of your facial nerve. Fine. And this is the pyramid with a stapedial tendon. Important things about sinus tympani that you have to know. There are many types of sinus tympani based on the shape and based on the depth of the sinus tympani. So based on the shape, what happens is because of the ponticulus, the normal classical shape is this one, which I have already described to you. And once the ponticulus is dehiscent or there is less of ponticulus or not complete ponticulus, then there is a confluent sinus tympani. It is going and merging with the posterior tympanic sinus. Then another thing is there is one extra partition between the ponticulus and the scubiculum. There can be one extra bone in between, because of which there will be partition sinus tympani. And also sometimes there is a restricted shape of sinus tympani. That is because there is a high jugular bulb. Those are your based on the shape. Based on the depth, why it is important to know based on the depth? Again, this is important surgically. You have to correlate with the high resolution computer tomography of temporal bone uh, before your planning of surgeries. Like type A, sinus tympani is nothing but the classical type. Here you can see the medial border is till the facial nerve. But in type B, it is a dip sinus tympani where the medial border goes medial to the facial nerve. Okay. And here what happens is you cannot access directly. You have to use angle instrument for this. And type C is your deep and posterior sinus tympani. It means it is having further more extension beyond the facial nerve. So in this case, even with angle instruments, you will not be able to approach. So prior to surgery, you have to plan it out that you may have to go retrofacial approach also to clear out the sinus tympani. Fine. Again, important thing is Prusak space. You have to know with the diagram. The boundaries are laterally we have the pars flaccida. In the neck of Malleus, we have lateral malleolar ligament, which is the superior boundary. And the floor is mainly by the lateral process of Malleus, and the medial part is your neck of Malleus. Okay, so this is the Prusak space. Why it is so important and why I'm like telling you for this space with the diagram and all is that cholesteatoma sequestration is a very common site. I'll be showing you the panoramic view of medullary cavity. This is with the ossicles, which you can see. This is the handle of Malleus with umbo. Then we have the long process of incus, lenticular process. There is the stapes with the foot plate. This is the stapedial tendon, pyramidal eminence. Promontory, these are the retrotympanic areas. This is your hypotympanic area, epitympanic area, protympanic area, and epitympanic area is the above area, okay? Once we remove the ossicles, here we can see the facial nerve very properly, okay? Another important thing about medullary anatomy is the mucosal folds, which I will be coming later. Now coming to the part of medullary which helps in physiology of hearing. So medullary is termed as impedance transformer. Why is it so? Why is the impedance transformer required in this kind of cases, or why it is needed in a human? When the sound travels from the air to liquid medium. So what are this? This air will be there in your external ear and the middle ear. In inner ear, it is mainly filled with perilymph and endolymph, which is a liquid medium. So once it goes from the less dense area to the higher density area, then there will be dampening of the sound. For that sound to be amplified and so that we can hear properly, we should have an impedance transformer. And that is our middle ear. So what middle ear does is impedance matching. First, they have three mechanisms of that. One is surface area ratio of the tympanic membrane to the stapes footplate, which comes around 18.75 is to 1. Okay, this is around 60 millimeters square of the tympanic membrane and 3.2 millimeters square of your stapes footplate surface area. Fine. In this whole thing, there is a gain of around 26 decibel in a theoretical ear. Mind it, in a theoretical ear. Then the lever action of tympanic membrane. That is the ossicular level. Here we see the length of the handle of Malleus to long process of incus. Here what happens, it transforms the low pressure sound into high pressure sound. and there is almost a gain of 2 decibel. Then the other thing that is important here is about the curvature of the tympanic membrane. And the handle of malleus here acts as a leverage. So in a theoretical ear, means where there is all other things are cancelled out. There the gain is around 28 decibel, but in a normal middle ear, the gain is around 20 decibel. This is a diagram taken from some book where we can show where it is shown how the sound is traveling from the tympanic membrane to the ossicles to the inner ear. This is the lever system which is in the ossicular chain. What is impedance efficiency? When there is a middle ear, then 60% of the sound can be transmitted and absorbed in the cochlea. But in case there is no middle ear, only 1% can be absorbed in cochlea. So this is the importance of middle ear. I already have told you what is the importance of tympanic membrane and how the sound is traveling from EAC, like external auditory canal, to the tympanic membrane. And then other things that plays a role is the eustachian tube. This eustachian tube is nothing but a tube connecting your middle ear to the nasopharynx. What is the role of eustachian tube? It mainly, in a simple terms, you can say it as it regulates the pressure in a middle ear with the surrounding environment. Other thing is your middle ear cavity. Middle ear cavity, I have already told you, 6 walls are there. So there will be reflection that will give an additional drive to the membrane function. And also the middle ear mucosal folds, which I'll be describing later. What is attenuation reflex? It is a protective reflex of the middle ear, which reduces transmission to the inner ear and avoids its damage. What happens is when loud sound occurs, then it will be carried to the cochlear nucleus via the auditory nerve. And there is interneuronal connection and facial nerve nucleus gets stimulated and contraction of stapes occurs. And also some amount of contraction occurs in the tensor tympani muscle, which is a minor one. Here, the latency period of this attenuation reflex is around 40 to 150 milliseconds. What happens here is the tensor tympani muscle pulls the handle of malleus inward, while the stapedius muscle pulls the stapes outward. So what happens is both sides will come together and there will be rigidity in the ossicular chain. So ultimately, the conduction of low frequency loud sounds will be avoided here. Okay. In damaged middle ear scenarios, the whole transformer mechanism that I have described, this will be damaged in this when there is a damaged middle ear. And also there is something known as phase difference or differential pressure levels between the two windows. I have described you about oval window and also the round window. For a sound to get transmitted, there should be a phase difference. Okay, so if the oval window is in compression, the round window should be in rarefaction. So that the sound gets stimulated, it will stimulate the outer hair cells, then inner hair cells, the auditory nerve, then goes to the brain, right? So these things will be hampered in case of damaged middle ear scenarios. Very important thing that we usually miss is the physiology of ventilation when we are talking about the physiology of middle ear. So what are the factors involving in the physiology of ventilation of the middle ear? One, I have already described you, eustachian tube function. Then we have the buffer mechanism and transmucosal gaseous exchange. So the eustachian tube function, I have already told you one about the pressure equalization. Another thing, it acts as a conveyor belt. Whatever dirt is there in the middle ear can be thrown out to the nasopharynx with that conveyor belt mechanism, which we usually have in our nose also, by the eustachian tube. So these functions are required for a proper ventilation of the middle ear. Then buffer mechanism. Buffer mechanism is mainly seen in the mastoid. Mastoid is nothing but a lake of air-filled spaces. So the buffer mechanism mainly depends on Boyle's law, which is pressure is inversely proportional to the velocity. So what happens is in a well-aerated mastoid, the pressure will be less and the ventilation will be proper. But in a damaged mastoid where the volume will be less, the pressure will be too high to maintain that. So the physiology of ventilation will be hampered. And another thing is transmucosal gas exchange. That you can think as lung alveoli system, how the gaseous exchange happens. There will be mucosa, from there the gases will get exchanged to the arteries or the vessels, wherever is there. So in case there is inflammation or any stasis of the fluid, then this will be hampered. Fine. In this whole physiology of ventilation, you have to know one thing. The middle ear can be, imaginarily you can take it as posterior superior quadrant and anterior inferior quadrant. Posterior superior quadrant will have the epitympanum and the mastoid. And anterior inferior quadrant will have your mesotympanum, hypotympanum, and others. So this posterior superior quadrant, the mucosal lining is mainly your flattened cuboidal cells without any mucus secreting cells. But the anterior inferior quadrant, which is lined by your respiratory mucosa. So it is mainly your pseudostratified mucosa with mucus secreting cells. Okay. So I've been asked about the electrophysiology of middle ear, but it is mainly in the inner ear when there is a traveling wave theory. For that, the scala vestibule and scala tympani will get vibrated. The membranes will be vibrated. Outer hair cells, then stereocilia, kinocilium, and all those things will happen. Action potential will occur. Then the thing will be transmitted to your auditory nerve in the brain. So that thing probably will be discussed properly in your inner ear chapter. Now coming to the main point that I have been telling you from before, middle ear cavity spaces and folds. Embryologically, I'll not say you much. From 3rd to 4th month of gestation, it develops, and it develops from the first pharyngeal pouch into 4 sacci or pouches. So it mainly comes from your eustachian tube opening. First will be your saccus anticus medius, then your saccus superioris and saccus posticus will be there. Fine. In this diagram, you can see anticus, medius, superioris will go up from here. This is the eustachian tube opening area, and this is your posticus. Fine. Multiple folds and ligaments of middle ear are there. Don't go and mug up everything. I'll just show you. Once you know from where it is arising, then you can eventually tell about the folds. Fine. So now coming to this epitympanic diaphragm. Diaphragm means what? This will be a plate like of thing which will be dividing mainly your mesotympanum from the epitympanum. This is the head of malleus and this is the body of incus. So head of malleus, the folds that we have is the superior malleolar fold with superior malleolar ligament. Then anteriorly we have anterior malleolar fold and ligament. Medially we have tensor tympani fold. Laterally we have lateral malleolar fold. These are the folds of your malleus. Incus, coming to incus, you have the superior inguinal fold with ligament, lateral inguinal fold. Medially we have the medial inguinal fold which continues in your stapes. Okay, then we have the osticular folds and all. Here I think you can see this green colored holes. These are nothing but the isthmus tympani anticus and isthmus tympani posticus, or simply you can say as anterior isthmus and posterior isthmus. These are nothing but openings through which the epitympanum or epitympanic area is ventilated from the mesotympanum area. Right? This is another diagram which is showing your lateral malleolar fold and the superior malleolar ligament. Okay, this is the malleus. And from lateral to medial, if you go and see, here you can see the lateral inguinal fold, superior inguinal fold, Prosac space is here, and the posterior pouch of Bondros. Here is the interosticular fold, and behind is your medial inguinal fold. One thing I wanted to tell you, this is a thing like ventilation routes and their blockage. This epitympanic diaphragm that I have already mentioned to you, with a complete tensor fold means this tensor fold is complete. So in case of this patients, the isthmus is blocked. There is no other way to ventilate the epitympanum. So the disease will be entering in your epitympanic area. But few lucky people are there. Around 25% of the population, it is said like tensor tympani fold is dehiscent. On that case, the aeration can even happen from the tensor tympani fold. So in this kind of patients, there will be very less development of the disease compared to the person who is having a complete tensor tympani fold. This was the epitympanic diaphragm was mainly formulated in 1946 by Setelier and Lemon. We have to know about something known as selective epitympanic dysventilation syndrome. It is almost the same thing that I have described just now. Isthmus blocus is there, complete tensor fold is there, and there is selective epitympanic dysventilation, even with functioning eustachian tube. Okay. Now, this is the video that I'll be playing to everyone so that I can make you understand more about the mucosal folds. So here is the incudostapedal ligament. This is the yellow color thing is your scutum, the lateral attic wall. So once we remove the scutum, we can see the epitympanic area. Fine. So here is the neck of malleus, head of malleus. Then we have the body of incus. Then this is your lateral inguinal fold. Then below is your long process of incus. Then is your lenticular process. Then the stapes, anterior crura, posterior crura, and foot plate. Fine. This is the stapedial tendon, the pink colored one. And there is the tensor tympani fold. Okay. Now, with the malleus, I am describing the superior malleolar ligament with the superior malleolar fold. The dark brown is the ligament fold and white is the ligament. This is anterior malleolar ligament and fold. This is tensor tympani fold. This is superior inguinal fold. The purple colored one with the ligament, which is a thickened one. Then the light brown color is your lateral inguinal fold, and this is medial inguinal fold. You can see medial inguinal fold, there is two openings. Okay, so this is your anterior isthmus and posterior isthmus. Fine. These are the connections to your mesotympanum with the epitympanum, which I was telling you. This again comes down to the stapes. You can see here in between the crura also there is crural fold. Fine. So this whole thing, the brown colored one, then the lateral malleolar fold, anterior malleolar fold, red color tympanic fold, then we have the medial inguinal fold. All this forms the diaphragm. Okay. Then the only openings are through which ventilation occurs are those two. Now coming to anterior malleolar fold and posterior malleolar fold. Here what happens is this green colored one is the lateral malleolar fold. What they are trying to describe here is the Prosac space. Okay, so this is the scutum. This is not subrevenous. Then we have the lateral malleolar fold. That they are showing is the neck and the lateral process of malleus. And above we will have the pars flaccida. So this is whole your Prosac space. Now what happens is this superior malleolar fold will divide the whole epitympanum into anterior epitympanum and posterior epitympanum. Fine. The superior inguinal fold will divide into medial inguinal fold, and again lateral one will divide into superior inguinal space and inferior inguinal space. This inferior inguinal space is communicating with the mesotympanum. So any disease in this inguinal space can go in through the posterior isthmus into the epitympanum area. Fine. So any disease in the posterior superior part will go into the epitympanum through this isthmus. And if it goes to the Prosac space, then it will enter the superior inguinal fold to the mastoid antrum. It will go. Okay. And two important things I'll be showing you here is the anterior pouch of von Trost and posterior pouch. So you can see the posterior pink color ligament, malleolar ligament, and the space between the pars flaccida. This is your posterior pouch of von Trost, and anteriorly with the anterior malleolar ligament and the pars flaccida is your anterior pouch of von Trost. What happens to this is any disease in the epitympanum will go into your mesotympanum area from this, or from mesotympanum can go into your epitympanum area. Okay. Thank you very much for your patience listening. Now, I have taken my references from Scott Brown, Cummings, Sambok, Livio Prosetti, and also the video that I have taken. So this is our today's topic of gross anatomy of middle ear and physiology, and also the mucosal folds. Thank you very much, everyone, for your patience listening.
Thank you, Dr. Anuradha. It was a fantastic presentation, very, very good presentation, very nice presentation. So can I ask Dr. Monish? Dr. Monish, please.
Good evening, everyone. I think it was a wonderful presentation. I loved the model, the video which you showed, and the line diagrams especially were wonderful. Now, if I could just, give a few inputs, if that's okay with you, things
sir.
which I think, can be changed. And, I just noted down a few points, and if I could just share my screen, if you could allow me to do that, then I can just,
Dr. Rohan?
a few things which I think which could be different.
Dr. Rohan?
Okay, is the screen visible now?
Yes, yes.
Okay, perfect. So,
Yes.
first of all, thank you, Dr. Somway, Dr. Fauziya, Dr. Anjan and Dr. Gautam for inviting me here. It's a wonderful initiative, and this topic is, very dear to my heart. Otology per se and rhinology, these are two things which I really love doing, and the talk was really important. I think this is what forms the basis of all the otology which we do. Now, apart from the things which she told, and I'm really happy she covered a lot of things, there are a few things, which I think I would like to, highlight upon. And these are the things which I noted down during this presentation. So it's a very basic presentation because it's just what I noted down during this whole talk. One thing which you mentioned was COG, right? And so and let's keep it interactive if we can. Can you or anybody else in the residence or the senior residents just tell me what COG really means? Is it a word what's the meaning of COG? Any ideas? Why is it called COG? The structure is, we all know, it's a structure which comes vertically down from the tegment, divides the attic, the main attic from the anterior appendipanic recess, right? And that's pretty right, which you mentioned. And just a trivia kind of a thing, what COG really means. Do you have any ideas? Any of the junior residents or senior residents? That's an interesting thing. That's why I thought I would just, share this thing with you. So COG is actually, it's an acronym for center of gravity, right? So if you place the temporal bone in its anatomical position, this particular place or point is what forms the center of gravity of the temporal bone, and that's why it is called as COG, right? So that's very interesting thing which I learned about this, and therefore I thought I would share this with all of you. Now, when you talked about the various boundaries, it's always better, and you did talk about the facial versus the clinical implication, but there are a few other clinical implications which are important. So, when do we call a jugular bulb a high jugular bulb? How do we define that? Or let's say, how do we define a low-lying dural plate? When I started doing mastoids, it would be very common for me to injure the dural plate and, kind of expose the dura. And I always used to mention in my operative notes, it was a low-lying dural plate, right? And it's a very subjective thing. But what is the definition for a low-lying dural plate? That's what I would, want people to know. Now, you talked about oval window and round window, and if I'm not wrong, you mentioned that oval window opens. Where does it open? What did you say?
Scala
Can you?
vestibule, sir.
Wonderful. Scala vestibuli of the which part of inner ear? The round window opens in the scala tympani of the basal turn,
Yes,
and
sir.
the waves, that's how the traveling wave travels, right? Now,
Yes,
where
sir.
does the oval window open? The scala vestibuli of which part? This has to be in communication, right?
Yes,
The
sir.
wave comes from
It
scala vestibuli and then comes to the scala tympani. The traveling wave, that's how the waves would travel, right? Where does
Yes,
this
sir.
oval window open? Which part of an area? Scala vestibuli is the membranous part of tympani vestibuli, but which part? So round window is basal turn, cochlea, oval window. What lies in relation with the oval window?
um,
Any guesses?
it will be the same part, sir.
It would be the same part, right? You would imagine
Uh,
it's opening in the basal turn of cochlea,
yes, sir.
scala vestibuli, scala tympani, and that's how they communicate with each other.
Yes,
And
sir.
that's not what really happens. And that's what's interesting. That's where I think an anatomy class should always have radiology going side by side. Now, if I were to show this on radiology, and I would probably do that, I just copied one of the scans as fast as I could. Probably we would really see that. Again, the round window shape, which you mentioned, is usually what we consider is to be, it could be a variable.
Yes,
You
sir.
mentioned very correctly, oval window is a bean shape or a kidney shape thing. Round window
Triangular.
considered to be triangular, but actually it is not. Again, very important for us, and I would talk about that. Sinus tympanic medial boundary, you mentioned it to be promontory, right? In your presentation, what's the sinus tympanic medial boundary? Promontory. Now, is
Yes,
it
sir.
really promontory is again something which I'll discuss, and that's where I think radiology comes in, because a temporal bone dissection is not something which you do always. A TBD would show you all these things, but radiology would tell you more. So let's come to what I was talking about, low-lying dural plate. Now, how do we define a low-lying dural plate? The most interesting thing is this part of a scan. If your dome of superior semicircular canal, right, is higher than the level of the tegmen in the middle ear, it's considered as a low-lying dural plate here, right? That's a definition which is used. Now, this is a very interesting thing in itself, because how many times have you really seen the superior semicircular canal in your whole life in a surgery? Majority residents won't, majority ENT surgeons won't. But still, this is the definition. Why is this the definition? Because we ENTs are slow to do it. The neurosurgeons defined it. The neurosurgeons actually went about defining a low-lying dural plate with respect to the superior semicircular canal, right? Because they do lateral skull-based surgery usually, and they would be using for the middle cranial fossa. The superior semicircular canal is a very important landmark, and that's why this remained. I'm not against this, it just shows that this is not very clinically important for us, right? Because you won't see the superior semicircular canal in majority of your surgeries. So it's only if the patient has a CT scan and using this definition, can you go about it? So if someone of us really gets active and really defines a low-lying dural plate, that is what an ENT surgeon needs. Otherwise, this is a definition which stands in the whole world today. Something similar is with the high riding jugular bulb. Any guesses how do you define a high riding jugular bulb? When do you call it as a high jugular bulb? I would
It is
always want it to be above what? Go ahead.
above the tympanic cavity floor, sir.
Exactly. So if it is coming into the hypotympanum, bulging into the middle ear, or let's say coming above the annulus in the posterior canal wall, or covering the round window for cochlear implants, that is how we would call it. Now, how do we define that? Is something very different, right? So the classical definition, and this is the whole grading which exists. It's not just one line. This is a whole grading which exists for a high reading jugular bulb. Types of high jugular bulb. Now the basic definition is if it is above the level of inferior margin of posterior semicircular canal, it is called as a high jugular bulb. Right, that's the most basic definition. If I were to ask one single line, what is a high jugular bulb? That's above the inferior margin of posterior semicircular canal. And then all the types are divided depending on the basis of whether it is dehiscent into the middle ear or without dehiscence into the middle ear. Let's see a few scans, right? So these are the various types of scans which I could, gather with, when I see all these patients, I keep a record of the scans which you're seeing. This is the posterior semicircular canal. This is the inferior margin. If it's below this, I'm not worried at all. So by definition, this remains a normal type 1, no jugular bulb or not a higher jugular bulb. Now this is another section. That dot is your posterior semicircular canal. This is your lateral one. This is your superior one. If it's going above this level, right, this becomes a type 2 now, right? This is type 2. Now, if it is dehiscent into the middle ear, this is 2B. It may not be dehiscent always, right? So it may remain type 3 without dehiscence. So when you mention it is not coming above the tympanic floor, it would still be type 3, but type 3A would not be dehiscent into the hypotympanum. So for you, it doesn't make a difference, but for neurosurgeons, it makes a huge difference. Again, this grading is given by neurosurgeons, right? So this is how it becomes dehiscent here. Again, then it can be type 3 is above the level of posterior semicircular canal, but below the IAC, right? So this is how it remains, and then it can be dehiscent into the IAC. So these are the various gradings, but the most basic definition is inferior margin of posterior semicircular canal. If you want one answer, this is what it still remains as, right? Then the round window shape, which I talked about, which you mentioned as triangular, and I'm not against it completely, but that's not the real answer. It's actually something like this Pringle chip, right? You have eaten a Pringle chip, I hope you've seen it. This is how
Yes,
it
sir.
really is, right? So it's kind of a saddle shaped thing, right? Double convexity. And in terms of physics, it is actually called as a hyperbolic paraboloid. That's a very interesting term. That's what the shape of round window is. And why is it so important for us? So when you're doing cochlear implants, right, and when you're going through the posterior tympanotomy, the visual axis of a posterior tympanotomy, it is something like this. The round window is placed, I don't know if you can see my hands here, but the round window is placed something like this, right? So I see only this part of the round window. I don't see this part because this is in direct access to my vision. So this part is like hidden. It's right in the straight line. So I just see this part. And this is good.
Yes,
So I
sir.
see only the anterior inferior part of round window. I don't even see the posterior superior part. Now, why is it important for us? So the anterior inferior part is vertical, which we see. Posterior part is horizontal. When the patient is lying down or standing straight, this is horizontal. So we don't see the posterior superior part at all. It's not easily visible, right? Why is it important? Because this part is very close to the osseous spiral lamina. If I were to put my electrode through the posterior superior part of the round window, I would hit the osseous spiral lamina, and the electrode may get deflected into the vestibule, something like this. So if it's lying in the vestibule, you see this is your vestibule area. That's what it is. So the electrode has gone into the vestibule because when the surgeon was doing it, he or she went too posteriorly instead of remaining in the anterior inferior part where you usually are, and therefore went into the vestibule. So it's good if you're not seeing the posterior part. Don't try to be very posterior. You just want to remain anterior inferior, and that's where it's good. So the shape is in reality a hyperbolic paraboloid, right? And the anterior inferior part is what you're concerned with. Now there are a few other terms which are coming in when it comes to the middle ear anatomy. So the medial wall, if you look at it, and these are all the endoscopic anatomy terms, which are becoming very important now. So if you're talking about giving a talk on this, you can't do without talking about these things. So I'll just briefly mention these. If you can see the screen, this is the round window, right? This is your promontory bulge, fine. This is the whole area of hypotympanum, which we usually call as hypotympanum, the pneumatization which happens. This is superiorly, I'm not really going there, but the retrotympanum and the hypotympanum is what's important for us, right? So the round window, the roof of round window is what we call as the tegmen of round window. Like the tegmen of the middle ear, there's a tegmen of round window, which is what you need to drill to expose the round window really well. This is the anterior pillar of the round window. This is the posterior pillar of the round window, right? So these are terminologies which are very authentic ones, which are used worldwide now. These are two terms, anterior pillar, posterior pillar. So when you're doing a cochlear implant, you drill on the tegmen and then you drill on the anterior pillar a bit. You don't drill on the posterior pillar at all. You don't want to go posteriorly, as I mentioned. Then you come to a term called fustus, right? Fustus is a thick bar of bone which through which the round window is attached inferiorly. This is what gives round window the tensile strength. This attachment is what is important. And fustus can be of various types. Let's not go into details of those. But remember, this is a very important piece of bone, a thick piece of bone, which gives the round window its tensile strength. And you would always see this. This is a very important landmark which is present in all the temporal bones. Go more inferiorly and anteriorly from the posterior part are these variable pneumatizations. Now, if it is a very well pneumatized temporal bone, you would see a lot of pneumatization, and there will be a thick bar of bone again, which is separating two pneumatizations. This bar of bone is what we call as the funiculum. The funiculum, right? Funiculum divides this whole pneumatization into the hypotympanum anteriorly and the posterior retrotympanum posteriorly, right? That's funiculum, that's fustus, anterior pillar, posterior pillar, tegmen, round window, and this whole area, this pneumatized area is what we call as the area concremitata, right? This AC, when you see this here, this whole area is that, right? So these are all the terminologies which, as you grow, you will probably come to hear a lot, but it's important that you kind of start focusing on these. Now, this is what I meant by it. If you look at radiology, this is your sinus tympani. Fine. This is your facial nerve. So when you said the lateral boundary is the facial nerve, I was really happy to hear that, right? This is your facial nerve. What you see here is, if you can make that out, this is the crura, the stapedial crura. Can you see that? I'm not sure if it's very well visible, right? Now this
Yes,
stapedial
sir.
crura is opening here. That is your oval window. It's
Yes.
connecting here, and that's not your cochlea. That's in fact the vestibule. So if you remember your stapes surgeries, we always say the piston should not be over-inserted, but it will injure the utricle or the saccule. The utricle and the saccule. We always mention these two things, which are a part of vestibule. So the oval window is nowhere in relation to the cochlea. That's just our undergraduate books which made those diagrams, which made us feel that it's in one cochlea, the basal and superiorly oval window, but it's actually a very different thing. It's a saccule, and that's how VEMP, when you do it, the theory of VEMP, vestibular evoked myogenic potential, is giving a loud sound which travels through the saccule, and VEMP actually travels the saccular function and not the cochlear function. It checks the saccular function, and that's why it checks the saccular function, because in reality, oval window and stapes are in relation to the saccule more than any other thing, right? So this is your saccule. And look at the medial boundary. The promontory is made by the basal turn of cochlea, right? The bulge of the basal cochlea is what makes the promontory in the middle ear. You have the sinus tympani here. What is the structure? Is this the cochlea?
Yes, sir. The cochlear
No,
duct.
no, it's not the cochlear duct. Cochlea is way anterior. This is whole the cochlear structure. These are the cochlear structure. This is the internal acoustic canal. That's your vestibule. That's
Vestibular
your
duct, sir.
cochlea. No, it's not the vestibular duct. That's where
No,
radiology comes in. This is okay. Let me just color this up for you. I'm happy you're answering things. I don't like quiet people, so I'm happy you're answering things. This is how it. If you color this all up, if you color your CT scan, these are the various things you look at. These are the turns of cochlea, the apical, middle, and the basal turns. There are three turns. This is the vestibule. These are the crura, right? And then you have something coming from the vestibule posteriorly, which forms the medial boundary of sinus tympani. That's your facial nerve. Coming from vestibule posteriorly, what will you have coming from vestibule posteriorly? Okay, I think we can someday have a radiology class, and I would love to be a part of that again. If you have this.
Endolymphatic duct, sir.
Duct.
No, no, this is your posterior semicircular canal. And when you say endolymphatic duct, you see vestibular aqueduct. You mentioned vestibular aqueduct earlier. The content of vestibular aqueduct is an endolymphatic duct, so it can't be the same, right? If I said no for vestibular aqueduct, it won't be the endolymphatic duct. Endolymphatic duct you can't see on a CT scan, you would see only on MR. CT
Yes,
would
sir.
show you vestibular aqueduct, and MR would show endolymphatic duct. Endolymphatic duct is a membranous structure. Vestibular aqueduct is a bony structure. The thing remains the same. Let's not go into radiology a lot. I just put this photograph up so that you understand that the sinus tympani, if you go in a temporal bone and you drill it out well, you would see the posterior semicircular canal really forming the boundary of the sinus tympani, right? But in radiology, you can see it very well. Sinus tympani, facial nerve, and then you have the posterior semicircular canal, right? So stapes, oval window, the saccule out here. That's how it's related. Fine. Just wanted to briefly outline this. This is the normal way of seeing a CT scan. This is the funny or the more exciting way of seeing it, like the models which you shared. But this is what becomes important for us, right? That's where I end. Thank you so much. I mean, I really loved your talk. Just wanted to share
Thank you, sir.
this as to share knowledge. I'm not trying to say that you said some things which will need to be changed, just that this is a very thing close,
Yes, sir.
very close to my heart, and I'm so happy you really talked about it so well. And thank you, everyone.
Thank you, Manish. So nice
Thank
description.
you, Dr. Manish. We have
Thank you so
learned
much.
many things from you
No, sir,
Yes.
today.
it's a mutual thing always. I learned a lot when she was speaking. So
Right.
wonderful.
Can you take the questions, please, Manish?
Oh,
There are some
I'm supposed
questions,
to.
very few questions, but
Okay, I'm supposed to answer that. That's a difficult thing then. She
CBCT,
should be
Dr.
answering it.
Everyone has asked CBCT, importance of CBCT.
Okay, wonderful. CBCT is a new tool. I do get it at times. Now, where do you want to get CBCT done? One advantage of CBCT is that it is a very low radiation. The problem with, and it is very less time consuming. It is also something which gives you very less metallic artifacts. So if you have, let's say, a titanium pistol in place, or if you have a cochlear implant in place, a normal CT would give you a lot of artifacts. A CBCT will not. That's one. If you're doing in children, CBCT really works out well. CBCT would give you, very good outlines for autosclerosis. So again, in autosclerosis is considered to be very good, much better than probably HRCT. And the low radiation is helpful. So that's where cone beam CT comes in. It is also very good for maxillary sinuses at times, but in the temporal bone, it's post cochlear implant patients and autosclerosis where it is definitely way better. And a low time resolution, low time requirement, and um, less radiation is always something which makes it better. So that's what it is.
Another question by Dr. S.V. Kukan sir only. Significance of processus cochlear formis.
Oh, that's interesting. Significance of processor cochleariformis. Processor cochleariformis is a very sturdy structure. It doesn't get eroded even with the most extensive cholesteatomas. So if you have to use a landmark for the first genu, it's the processor cochleariformis. So processor cochleariformis, just superior to that, you will have the first genu. And interestingly, though we never use it, just inferior to the processor cochleariformis will be the apical turn, so the middle turn of the cochlea. It's rarely required, but the middle turn of cochlea, if you have to open the middle turn, go directly perpendicular, just inferior to the processor cochleariformis, 2 millimeters interior to the oval window. you would have your middle turn. So it's a very good landmark. And obviously we know the tensor tympani comes and attaches there and then hooks up and goes to the malleus. So that's all I know. If somebody else wants to add on.
Okay, another interesting question by Dr. S.B. Fukan is, if the ossicles, there is no ossicle, how many loss of hearing will be there?
Yeah, Fukan sir is taking my life viva here. Yeah, this is not fair. So if there are
He is
no,
very active and he is always, mostly all questions are by him only.
I know, these are tough questions. So, uh, if there are no ossicles in the tympanic membrane is intact, right? So that would mean if you have any ossicular discontinuity or all ossicles are absent and the tympanic membrane is intact, you would have the maximum conductive hearing loss, which is 60 decibel airborne gap. You cannot go more than that. So it's a 60 decibel airborne gap which will. If however the tympanic membrane is not there and the ossicles are absent, it's just the stapes foot plate which is not fixed. It's the mobile stapes foot plate. Then there is a the hearing loss of around 30 to 40 decibel, goes up to 40 decibel usually.
Another question by him only. Has funiculus has any significance?
None other than using as an anatomical landmark to decide whether you are in the hypotympanum or posterior retrotympanum. Now, what happens here, sir, is that if your posterior retrotympanum is very well pneumatized, you may have something like what we call as a subcochlear canaliculus, right? And subcochlear canaliculus is a very well pneumatized posterior retrotympanum cell running inferior to the cochlea, and I can show it's a radiology someday. I have a lot of sections, and if it's a very deep thing going in, you would in initial part of your career doing cochlear implants, you would confuse that with the round window because that's a head-on view. And there have been instances, I have revised two of them myself, when the surgeon has gone in and inserted the electrode in the subcochlear canaliculus and therefore landed up in the hypotympanum or sometimes even in the carotid canal by drilling through it, right? So this is the importance of that area. Funiculus per se has no, clinical significance. It's a good landmark to divide this, sometime between the hypotympanum and posterior retrotympanum. Sometimes we humans tend to make it too complicated. I suppose that's what something which is happening with the middle right now, but it's good to know. So I just mentioned it.
Can I have one question, Manish?
Sir, please.
Yeah, I'm Dr. Nayak. Meet you in Ceylon.
Yeah, I
Yeah,
remember, sir.
I got a question means I have a problems. When I did a cochlear implant, I just do a posterior tympanotomy. I cannot identify the round window.
Mm.
It's merged. So when I fail, I put the electrode already removed. I put in the mastoids, and the second time again I open up. At that time, I identified a round window. The round window usually some difficult cases.
We lost your voice, sir. You got muted.
Sound. Hello, Gautam na sound to mute হয়ে গ'ল নেকি?
Hello.
Now
Yeah.
it's good.
Now it is coming.
Then again, I open up. Then I follow the incas, the
Yeah,
incas, and I somehow I can identify the round window.
yeah.
Put the electrode, and after that is doing good. But that problem usually encountering sometimes. So
Okay. Yeah, I know.
you got my
So this
point.
is very interesting. Yeah, sorry, go ahead, sir.
Yeah, that is a problem because sometimes we do in a remote place, and
Yeah, I know. You may
if
get
this
stuck.
type of difficult occurs, so we have to go
Yeah,
for a
what to do?
second opinions. So
I know.
sometimes this is not possible also. So can I go for a second city in that case?
Why not? But if you've opened the implant, that's a problem then. I mean,
Yeah, I
so
opened the implant. I put in the
yeah,
mastoids. Again, in
mm,
second times I introduce it, identifying the round window.
yeah. So
Otherwise,
yeah.
huh.
Sorry. Otherwise,
Otherwise, the implant will be wasted if I put
I know.
outside. No.
I know. So I'll tell you what, the reasons why this happens, and that's a very interesting thing you mentioned it.
Hmm.
One is if in the meantime you have packed the posterior tympanotomy area with, let's say, adrenaline soaked gel foam or any kind of gel foam,
Yes.
the mucosa sometimes if it's edematous, it really gets decongested and you're able to see much better. That's one. Any oozing which disappears again makes the illumination better. So it makes it
Yeah.
much better. The other thing is, which is more important, is many times when you're doing a posterior tympanotomy, you're looking at through the microscope directly head on. So you're
Yeah.
able to see the stapedius, you're able to see the promontory and the posterior part, posterior to the promontory, and you don't see the round window, right?
Yeah.
Now what happens is round window is many a times hidden by this round window niche. So once you've done an adequate posterior tympanotomy,
Hmm.
what you should always do is to now focus your microscope from inferior to superior, because the round window would be hidden like this and your niche is covering it. So if you're looking at head on like this, you would never see it. But if you see it from here, you would start
Okay.
seeing it. And probably that's what is happening with you. When you are not seeing
Yeah.
it
Facial
initially,
also a little bit high. So it's
I know.
exposed.
Yeah. So what you can do is, instead of opening the implant, and I would not recommend you to open the implant without seeing the round window. If you don't see the round window, then you just tilt your microscope from inferior to superiorly instead of seeing directly from head on. Just tilt it a bit like this, and I'm pretty
Okay.
sure you will see it. That's one of the ways. The other way is you put in small drops of saline, 1 or 2 drops of
Okay.
saline in that area where you think your round window will be. And
Okay.
many a times the refraction which happens makes the round window really visible. And you start doing it with all your cases, you would love to see the difference which it makes. Or you can do it, you can fill the whole middle ear with saline, put your
Yeah.
suction in the editus area, suck on that editus area, and as the saline disappears, there'll be a fraction of a second when you'll see the round window, and then it will disappear again when the suction sucks out all the saline. But that will tell you where your round window is, and if you drill slightly in that area or you position your microscope somewhere, you would be able to see that. So, but sir, frankly, if you have not seen the round window, opening the implant is a very risky business to do.
Yes. Yes.
Don't open it. Rather, do a repeat CT and come back if you have to, but don't
Yeah.
open the implant. Sometimes if it's a very tricky thing, the implant would go waste, and that's a bigger
Yeah.
problem. So that's a risky thing. I would
Thank you,
usually
Manish.
open the implant after completely identifying the round window, and at times opening the round window to make sure there's no fibrosis and then go in. Right. So that's what I do.
Yeah. Thank you very much.
Thank you so much, sir.
Because we opened around it because we are working in a team now.
I know that
Yeah.
happened. But that's a
Yeah.
protocol which becomes really important at times.
Yes. Thank you very much. Thanks.
Thank
Thank you.
you. Thank you very much.
Thank you, sir.
There is another question. Importance. How to identify processes cochleariformis?
Oh, so processus cochleariformis. Um, Usually it's not a tricky job. If you really have to identify it, if your malleus is intact and you're looking from the posterior part of the malleus and you lift the malleus slightly with, let's say, a flap repositor or a pickup, you will see the tensor tympani going inferiorly attaching to the processus cochleariformis. It doesn't get eroded at all. If your malleus is absent, even then, if you go 2 millimeters anterior to the oval window, that's one of the other landmark where you would probably start seeing a projection from the middle ear medial wall and some soft tissue attached to it, which is the remnant of the tensor tympani on the processus cochleariformis. So you would always see it. It's almost never ever eroded. Unless the promontory gets eroded, everything gets eroded. That still be the last thing to get eroded. So you would see that.
Thank you, Dr. Monish.
Thank
May
you.
I invite our moderators to speak about the presentation and everything. Dr. Gautam Nayak and Dr. Gautam Nayak.
Thanks. Thanks, Fauzia, for allowing me to join in the academic activities. Presentation is very nice, very informative,
Lovely.
and we learn a little bit and from the presenters and from the Monish a lot of things because of relation of the anatomy and the radiology really is important, though it is not possible every times in academic institute also. So probably this type of activity will enhance our knowledge and we can exchange it. Thank you very much.
Thank you, sir.
Thank you.
Thank
Dr.
you.
Dr. Tilo Bhattacharya.
Thank you, Dr. Anudha. Special thanks to the Dr. Monish Grover for enlightening our knowledge. Thank you.
Thank you
For the
so much.
good
Thank you,
presentation.
sir.
Thank you, sir.
Thank you.
Very nice. Very nice, Manish.
Thank you, sir.
It is really, we have learned many things from you.
Oh, I learned it from Radha too, so loved her
Oh,
videos.
yeah. Yeah.
Thank you, sir.
Anuradha has done a very good job.
I am sure.
Everybody,
Yeah.
Thank you, ma'am.
we have selected this topic because it is very important and it is very
Yes.
less discussed. It is not
Yeah.
discussed. Usually, we discuss all
Yes,
diseases and
yes. No,
complications,
I
surgical
congratulate
anatomy.
you. I congratulate you because you have chosen the topic,
Wonderful.
right?
Thank
Yeah.
you, Dr. Mohammed.
I
You
love
have
this
chosen the
initiative.
topic, and Madam Hirano Madam also chosen the same topic.
Yes.
So same,
Hirana Madam has left. Actually, she has a program. She is in Kolkata.
yeah.
So she called me that I am going. Please, you manage
No,
it.
these are actually the basic thing for the PG students, right?
Yes.
So yeah. So if the anatomy is not clear, physiology is not clear, particularly the anatomy, so it will be very difficult to get. At present there is a very deficiency of getting the temporal weight temporal bone also. So many of your there. Yeah. So I think we have to encourage our all the medical colleges in the northeast to start
Yes.
up this all these temporal bone dissection rigorously, so that the our juniors, those who are coming, at least they will have the best knowledge about the temporal bone. That is the thing.
Yes. So now it is the part of giving vote of thanks. So I will be doing on behalf of Nebaoi. Uh, so respected President of Nebaoi, esteemed expert Dr. Monish Grover, dear Speaker Dr. Anuradha Deka, our distinguished moderators, and our dear senior members, colleagues, and participants. On behalf of Scientific Committee of Nebaoi, it is my privilege to propose the vote of thanks for today's enriching Nebaoi classroom session. We are deeply grateful to our expert, Dr. Monish Grover, for his valuable presence and insightful comments, which greatly enhance the academic depth of this program. It is really very thankful, Dr. Monish. We
Thank you, ma'am.
sincerely thank our speaker, Dr. Anuradha Deka, for
Thank
delivering
you,
such
ma'am.
important and informative, well-structured presentation, especially your video that added meaningful learning to all. Our sincere appreciation goes to our moderators for stretching the session with academic clarity and facilitating a productive discussion. And we extend our thanks to our President, Honorary Secretary, Chairman, Scientific Committee, and all office bearers of NEBOI for the guidance and support in making this program successful. I also thank all the participants who actively involved making this thing possible, the classroom. Once again, we thank you all for your valuable time and contribution. Thank you all.
Thank you. Thank you. Thank you
We
very
meet in
much.
next
Thank you.
classroom.
Thank you, everyone, for the
Thank you.
opportunity. And I would like
Good
to
night.
thank my HOD sir, who has really forced me to this, and then he has helped me out in the presentation also. So Sakrabarti sir is the
I
one
have
who
not
is
done
helping
anything.
me out.
I
Thank
have
you so
not done
much, sir.
anything.
You
Yeah.
forced her, sir. That's what is important. So,
That is important.
I have not
Guide
done.
and
And
Manish,
Guru,
I have not done
Guru should guide,
anything.
na? Guru
I
should
have
guide.
just gone through the slides. That's all.
And Fauzia ma'am also,
That's
she
all.
has been
I
a
have not
constant
done anything.
support. Then she is like looking after the presentation and everything is ready or not. I'm very thankful to her. And I
Thank
really
you.
learned a lot from the moderators and of course, Monish Grover sir. Thank you so much for giving the insight on the anatomy. And I really have learned a lot today. Thank you so much.